For most of you, Dr. Ali needs no introduction because many of you here are his patients, or you're coming because you've been to his website, eatmostlyfat.com, and you've seen the great work that he does there, disseminating information not only to his colleagues at the hospital system where he works, but also a great commitment to disseminating information to you. As I said yesterday when I talked about him, I know of no one other who has more compassion for his patients. And he's here doing this because of a great desire to change lives. And he believes wholeheartedly and practices what he preaches. It is my honor to introduce Dr. Nadir Ali.
Thank you, man. I'm going to start a timer for myself. So this disclaimer is that I've been offered a research professorship. I'm putting that up there, although I have not filled out the paperwork. So I wanted to start out with a metaphor. And the best way that I thought was to use my friend Dr. John Byrne. So suppose I'm a fan of the Philadelphia Eagles and watching a football game with my dear friend Dr. Byrne, who sadly, since he grew up in New England, is a fan of the New England Patriots. We've been friends, colleagues, we work in the same hospital. I respect him, but I think he is football challenged. So they are playing, it's the fourth quarter, 9 seconds are left on the shot clock. The Eagles are down by 5 points. And the ball is at the 12-yard line. So 4 wide receivers line up. The center hikes the ball back to the quarterback. He finds a receiver right in the end zone who makes a spectacular catch. And all the Eagle players run onto the field because it's a touchdown and they have won. But wait. Did the receiver get both his feet in? It looks close, so a jumbotron is called in for a review. And I, a Philadelphia Eagles fan, says, look at that. That was a great catch. It was totally in. Why are they even reviewing it? And even though I respect Dr. Byrne a lot, he says, that was completely out. He even had a scowl on his face. I can't believe the referee didn't see it. You must be crazy to think that it was in. So what just happened here? What happened here is that 2 friends watching the same event but came to 2 diametrically opposite conclusions. And I'm using a hero of mine, which is Dan Ariely, a behavioral economist, who says your bias and expectations dictate what you see in an event. So what I'm about to tell you is something that might be a transformative experience. You might think that, hey, this is something that helped me think about the cholesterol field in a different way. Or some of you might actually walk out from here because it may rock some of the foundations of the lipoprotein hypothesis and may create anger and resentment. And this, by the way, is Dan Ariely, and I would highly recommend that you read his book. So I want to take us back to the basics. I want to resurrect the cholesterol molecule that is much maligned. Because cholesterol is evolutionarily highly conserved. It's a part of the cell membrane. It gives the cell membrane the fluidity and flexibility so that it can protect our cells. I would not be able to think if cholesterol in my brain, these cholesterol rafts in my brains were not supporting the neurotransmitter receptors, my brain signaling, how my brain signals to another brain cell depends on cholesterol. I would not be able to stand here and give this talk without cholesterol, which is supplied by the LDL, going to my adrenal gland and jacking up my cortisol levels, the stress hormone, because I would not be able to deal with the stress. And so the hydrocortisone is a cholesterol product. We would not have are sexual differences. Women would not look so beautiful and men would not look so handsome. If the LDL particle did not supply cholesterol to the ovaries and the testes because they don't make any of their own cholesterol. They depend on cholesterol coming from this lipoprotein so that they can make estrogens and progesterone. We would not be able to absorb any fat if our liver did not make bile acids. Bile acids are a cholesterol product. They emulsify the fat that we eat. There is a 2.5 billion years of relationship between the human skin and the sunlight. So the sunlight hits the human skin and converts the cholesterol in our skin to vitamin D, which is a major determinant of where calcium goes. Does the calcium go into your bones or does it end up in the blood vessels of your heart? So, how does the body transport cholesterol? Cholesterol and triglycerides are fat, and if you take a beaker of water and you have oil in it, the oil and water don't mix. And similarly, our blood is aqueous, it's water-based, so it's not going to be able to dissolve these molecules. So how is it going to dissolve them? So the way it accomplishes that is by creating what is called a lipoprotein molecule. So it's got a protein, an apoprotein, which is an identifying protein that imparts its function. It's got a phospholipid bilayer, but the cargo of this, that is the inside of it, is cholesterol and triglycerides. So a lipoprotein molecule is a boat, is a submarine that is carrying cholesterol and triglycerides in our bloodstream. So the LDL is much maligned, and many cardiologists think that the only function of LDL is to cause heart disease. And I have put a non-exhaustive list out here. I'm going to let you read it. And I'm going to go through many of the functions of LDL and try to resurrect that molecule, saying that it may actually be doing us something good. So here is a VLDL particle, which is a cholesterol particle with an apoprotein, lipoprotein, a phospholipid bilayer, and the cargo being the triglycerides and the cholesterol. It is released by the liver, and it goes into the circulation, and it goes to the heart muscle tissue, to the skeletal muscle tissue, also to our fat cells. It drops off the triglycerides. And when it drops off the triglycerides, it becomes triglyceride poor or fat poor, and then it converts into an LDL particle. So that's how an LDL particle is most commonly generated. This is something that I have learned from Dave Feldman. I learn a lot more from engineers and from people who think outside the box. That the primary job of the lipoprotein VLDL that the liver is releasing is to supply energy, to distribute energy to our cells. Now, how much sugar energy do we carry? We carry very little sugar energy. The amount of sugar in our bloodstream, if you drain the entire 5 liters of blood from me, you will find a teaspoon of sugar, 5 grams. My liver can store about 100 grams of sugar energy as glycogen. That will last me no longer than about 6 to 7 hours. So the total amount of carbohydrates that we can store is only about 100 grams. We will not go into muscle glycogen, which is 300 grams, because that's not available for the brain to use. Now, how much fat energy do we have? This is, I think, Clark Gable. In 1960, he was 165 pounds. With the nutritional guidelines, an average American now is roughly about 30 pounds heavier. He's got about 65 pounds of fat as energy that he can use, as opposed to 100 grams. So I'm using this slide as an example to tell you how ridiculous sometimes the LDL argument can be, because these are 10 people who were healthy, and they were asked to do an 8-day fast. For 8 days, they did not eat any food. they had just water and salt, what do you think happened to their LDL level? What do you think happened to their cholesterol level? All of us believe that fasting is beneficial for us, and it has been proven time and time again through our culture. But if you look at the LDL, it was 112 at baseline. At the end of 7 days, it was 190, a whopping 70% increase. The cholesterol levels also went up. So why is this happening? Why is the LDL going up? Now, Dave is not here, right? Dave Feldman is one of my heroes. He's taught me a lot about lipidology, and he has done something really good for all of us who are in the low-carb world. I'd say Dr. Attia is somebody I respect, and they recently had a podcast. And I learned a lot from them, and there's a lot in here, so I'm going to unpack it. But if you look at me, and rather than looking at the slide, there are 3 things that I want to get out of it. One is that how is a person who is on a low-carb diet getting his energy from? Where from the fat that he is getting energy? The next thing is that what is the contribution of the father of the LDL to the making of the LDL? And number 3 is I want to leave you with a question. If the LDL goes up in a person who is fasting or a similar situation which is a low-carb diet, is that necessarily bad? Is it a homeostatic regulation of the body, or is that necessarily bad? So here is a situation in which a person is either fasting or a low carber, because the insulin levels have to be low for your fat cells to release the fatty acids. This is a triglyceride, it's been broken down. The fatty acids are being released. They can be directly used as fatty acid oxidation by the heart muscle, by the skeletal muscle, or these fatty acids will get into the liver. The liver has this unique ability to convert them into small molecules which are called ketone bodies. Ketone bodies are much like sugar molecules because they dissolve in bloodstream, and they can directly go from the liver, not only be used by the muscle and the heart, but the brain actually seems to function better on the ketone bodies. Amy Berger is going to be here tomorrow. She's going to tell you some unique information as to how the brain is able to utilize ketones better than sugar, especially as it gets older. Now, what else does the liver do with the fat energy that is coming in? So we saw that fat energy is coming in as fatty acids to the liver. It converted them to ketones, but it can also repackage that fat energy with triglycerides into a VLDL molecule. And this VLDL, which is a lipoprotein, will then go over into the muscle cells, into the heart, and what they cannot use, it gets dropped off into our fat cells. So this is a very efficient way. And a person who is fasting or on a low-carb diet is clearing these VLDL molecules rapidly from the circulation. So the VLDL molecules are disappearing, and as they disappear, some of them, smaller, are being taken up by the liver as VLDL remnants, but majority of them will then get converted to the cholesterol-rich molecule, which is the LDL. So, all right. So the liver puts out a VLDL particle that gets converted rapidly to an LDL particle. But in the situation of a low-carb diet, one of the things that Dr. Attia and others have taught us is that the liver produces about 40% of the LDL particles directly without having to go through that intermediate step of making VLDL. So in a fasting situation, the VLDL synthesis does go up. This is contributions of Dave Feldman, to which we should all be grateful. But one of the most important aspects is that fat energy does not stay in the bloodstream. Our body likes to keep the levels of both fat energy down and sugar energy down in the bloodstream. That is the best situation. You use up what you have so that you're not leaving fat energy hanging, and VLDL clearance goes up dramatically, and that's why people who are following a low carb diet have low levels of triglycerides or low levels of fat in their blood, whereas the LDL in some of us may go up dramatically. And that is where I would like to reach across the aisle and be bipartisan and say, I don't know for sure if that is necessarily good or bad, but if every marker in your body is improving, I would like to leave that question hanging. So again, 3 sources of energy from fat. Fatty acids are directly going to be oxidized. Fatty acids are going to be the liver being converted to ketone bodies and being used as fuel because these are water soluble, or they're going through a lipoprotein, which is the boat that is carrying the triglycerides or cholesterol. So here is a situation in which is called insulin resistance, which is what happens when you eat a standard American diet. And what you're seeing out here is that the fat energy is not being used by the muscle cells or by the heart because the enzyme that works to distribute the fat energy is not active. They are saying we don't need any because we are already full. So this is a non-insulin dependent diabetic. This is a person on a high carb diet. And what is happening to the VLDL molecules that their liver is putting out? They're not being cleared from the circulation, so you get what is called high triglycerides or high VLDL in your circulation, and that is not good. Severe triglyceridemia due to lack of VLDL clearance is the hallmark of insulin resistance. Now, I was talking to Dr. Berman here earlier in the break, and he was saying how fascinating it is that he's learning about mitochondria. So, CoQ10, to give you a metaphor, an engine cannot work without a spark plug. The spark plug burns fuel. Similarly, there's an engine in every cell of the body which is called the mitochondria. And the mitochondria needs a spark plug. And the spark plug for mitochondria to burn fuel is CoQ10. So this is an electron transport chain. It's just the mechanism by which the mitochondria work. And there is CoQ10 out here, which is the spark plug. And when that is active, it is creating this energy currency, which is called ATP, which drives our body. CoQ10 is a cholesterol product. So there are a group of researchers that took these rats and they divided these rats into a group that got a statin, the Lipitor that Dr. David Diamond was talking about. They gave Lipitor plus CoQ10, they get CoQ10 alone, and they gave placebo, and they said, we're going to measure and see what happens to these rats. We're going to weigh them to see if their muscle mass increases as they're growing. Are they growing their muscle? They put them on a rat exerciser called Rotarod to see how well their exercise performance was. And they did some blood tests to see if there was any evidence of biochemical muscle damage. So here is what happened to their muscle mass. These are the statin-treated rats, and their muscle mass went down. Whereas these are the control rats, and their muscle mass went up as they were growing. The CoQ10 was able to attenuate some of the effects of the statin. What happened to their muscle enzymes? So here is creatinin kinase, which is a muscle enzyme. The creatinin kinase went up in the statin-treated group, did not go up in the control group. This is another muscle enzyme which is called myoglobin. It went up nearly 5-fold in the statin-treated group and did not go up in the control group. Now, what about exercise performance? This is assessing exercise performance. And the statin-treated groups were the groups that had a reduction in exercise performance both at 14 days and 21 days compared to the control group. So there was demonstration of reduction in exercise capacity. Now, are there any human studies? So this is a human study that was done in 420 normal people. These are not patients who have heart disease already. These are normal, healthy individuals. And they had an activity sensing monitor on them to see how much activity they got. And the older you were, when you were placed on the same drug, which is Lipitor, and it's only for a short duration of time of 6 months. If you were 55 years or older, which is my age group, you can find that there was a significant reduction in your activity compared to if you were younger, especially if you were on a cholesterol-lowering drug. Is there evidence that humans taking this drug, that there is evidence of biochemical muscle damage? And yes, there is. This is the same study, 420 people. Those taking the atorvastatin, this is before the drug, this is after the drug. These are a group of placebo people. There is no change here. There is an increase in muscle levels, muscle enzyme levels, and there is an increase in evidence of liver damage in the statin-treated group compared to the non-statin-treated group. So there was evidence of both biochemical liver and muscle damage. Now you saw this slide earlier, and this is what is called a lipid raft, which is cholesterol rafts. These are neurotransmitters. So I am now moving on to tell you what is the role of cholesterol in the brain. If you take people who have schizophrenia, major depressive disorder, or bipolar disorder, and if they die of some other causes, and you compare them to normal people, take their brains out, and check what is the amount of cholesterol in the brain in these disorders was lower than in the control brain. If you take a group of rats, and you give them statins that cross the blood-brain barrier. So these are called lipophilic statins that get into the brain, which is the lovastatin and the simvastatin, and compare it with the group of control rats, you see that the cholesterol level per gram of protein is lower in the rats treated with the lipophilic statin. Now this is what is called a protein flotilin. You may not be able to see it at the back. I apologize for the small font. But what it shows is that this protein is the one that is anchored by the cholesterol raft at the membrane. It gives the membrane the potential to transmit signals. And the protein levels of that membrane protein was also down. So this is what is called a study, and I'm trying to bring about a clinical study to fit in this picture, and this is the Lothian birth cohort. There were a group of kids that were born in 1936. In 1947, they had a mental status examination. They were all brought back in the 2000s when they were 70 years of age. And the goal of the study was to do this. And it was to check their cognitive ability, their memory, their cognitive skills, and compare it with cholesterol. So let's see what happened. So in this group of people, the way you would define it is low cholesterol, which is in blue, less than 200, intermediate cholesterol, which is between 200 to 250, and high cholesterol, greater than 250, out here. Higher your cholesterol, lower your risks of having high blood pressure. Higher your cholesterol, lower the risks of having a stroke. Higher your cholesterol, lower the risks of having heart disease. What about memory function? This is cognitive ability measured as general ability, how fast you process information, what your memory was. Uniformly, the individuals with lower cholesterol had lower cognitive skills. The people with the highest cholesterol had the best cognitive skills. As you go on and look at verbal ability, as the cholesterol went up, your verbal ability went up. As the cholesterol went up, your IQ increased. Now, what about the effect of statins? Fortunately, of the 1,000-odd patients in the study, about 300 were on statins, 700 were not. So when you looked at cognitive skills on patients on statins, in terms of general ability, how fast they process information and what the memory was, it was uniformly lower in patients who were treated with statins compared to the non-statin users. And so is the case with verbal ability. Statin users had lower verbal ability and lower IQ scores. Now this is an association study. This is not a randomized trial. So you may say, it is not just cholesterol, but several of these factors between age 11 and 70, which is education, smoking, social status, exercise, that may have affected it. But nevertheless, it's a compelling argument for us to look at, especially in view of the reports of statin-induced side effects in terms of memory, mental fog, not being able to sleep. So this is a drug which is called lovastatin. It crosses the blood-brain barrier, and in 59 healthy men, it was given and they assessed what is called daytime performance. In terms of their reaction time, if they had a stimuli, how fast did they react? If they were distracted by something, if their attention was divided, how fast did they react? How vigilant were they? So the way the study was done is that at baseline, the first 3 days, they had these skills measured, their reaction time measured. Then for 21 days, they were given the drug. And at the end of 21 days, while they were on the drug, they were reassessed. So what happened? You can see that simple reaction time, divided attention reaction time, and vigilance, all of them increased significantly. In other words, it took more time for these people to respond in terms of reaction time when they were on statins compared to themselves when they were not on statins. Now, the cholesterol molecule is implicated in causing heart disease, but does it cause any host defense? Does it protect us in any way? So here is bacteria. These are Staphylococcus aureus, and they are infecting a rat lung. And the amazing thing about bacteria is that they're very intelligent. Before they decide that they're going to take over and cause pneumonia in a rat, they send out these marker protein, which we call AGR. And what the AGR does is that it goes in and assesses the milieu. It sees whether it is favorable environment for it to multiply. This is called quorum sensing. So what is happening is that the protein goes in, comes back and tells the bacteria, this is a great environment for us to multiply in. This study is done in mice. Let us have fun and let us all multiply and cause pneumonia. Now, what is the one factor that neutralizes this quorum sensing protein in the body of this rat in the study? And that is the lowly LDL molecule. I know that Dr. Kamana is here. She's an infectious disease person. So I wanted her to see this. So what happens out here is that the LDL, the lowly LDL, is the one that is coming in, squenching up the protein, the quorum sensing protein, and preventing bacterial virulence. And the bacteria decide it's not a favorable environment, let us quit. So neutralization of the bacteria by the LDL molecule. Now the bacteria also release certain inflammatory mediators, LPS and LTA. I borrowed this from Gary Fettke. This shows a nice sign of inflammation. These inflammatory mediators, through inflammation, cause cell death. What is it that reduces the inflammatory markers? And what reduces again is the lowly LDL. It goes in and squenches up the inflammatory markers, reducing the chances of this person having inflammation and cell injury. So that way the bacteria decide it is not a good place to multiply. Now there is a lot of similar information about rats that have deficiency of this LDL receptor. So this is the LDL receptor. It's on the liver, and what it does is that it picks up the cholesterol, LDL molecule from the cholesterol and takes it into the liver. This is the cycle it goes through. And then, as it goes through, it uses up the cholesterol and the protein and recycles it because the body does not like to waste things. There are a group of us who are called primary hypercholesterolemia, familial hypercholesterolemia, in whom the LDL receptor doesn't work, and so the LDL is left in the circulation and they have about 4 to 5 times LDL. So this is a rat study which I want to go quickly through, in which it's a rat model of LDL receptor deficiency. Their LDL levels are dramatically higher, about 5-fold higher than the control rat. And these rats were given either the inflammatory molecule, which is the lipopolysaccharide, or they were infected with bacteria, and the receptor deficient rat with high LDL was compared with the normal rat. What happened? What happened is that when you gave the inflammatory mediator, which is lipopolysaccharide, and it was a normal rat, it died at very low levels. On the other hand, if this was a rat that had high LDL cholesterol, the high LDL cholesterol protected that rat. And I'm going to skip some of these slides, but basically the information I'm going to convey to you is that there is evidence of host defense. That means that the LDL molecule imparts host defense characteristics to the individual. Here is a group of patients who are critically ill in the ICU, who are dying in the ICU. This is somebody that Dr. Kamana treats a lot. And you find that in this group of patients, lower their cholesterol level, the greater the chance of dying. Higher their cholesterol level, the better the chances of survival. This is follow-up over a 15-day daily cholesterol measurements in 7 people who went into the ICU with a severe infection from which they were dying. The people who didn't survive are at the dotted lines. Their cholesterol levels uniformly went down over time, whereas in the group in whom the cholesterol level recovered were the ones who survived. This is a very interesting study which is called the Leiden 85 plus study. About 724 patients in this town were followed for 10 years. They were followed for 10 years. And they were trying to predict whether high cholesterol predicted mortality. Did it predict heart disease? Did it predict cancer death? So again, the cholesterol was divided into low cholesterol, less than 200, middle 200 to 250, and high cholesterol was greater than 250. What happened? When you look at all-cause mortality, the lower your cholesterol, the higher the risk of dying. The higher your cholesterol, the lower the risk of dying. Now, people said that low cholesterol is a marker of bad health. They said, okay, fine, we will not count any deaths for the first 1 year. And when they did that, the outcomes did not change. So, when they looked at cancer mortality was uniformly lower in the highest cholesterol group compared to the lowest cholesterol group. And one of the reasons why older people die is lung infections, pneumonias. The incidence of pneumonia was the lowest in the highest cholesterol group compared to the lowest cholesterol group. Now, cholesterol is a very important marker in terms of the LDL supplying cholesterol to our testes and to our ovaries. When you take cholesterol-reducing drugs, your testosterone goes down. As you can see out here, these are groups that are taking cholesterol drugs and the testosterone is reduced. And if you take cholesterol-reducing drugs, you not only have a reduction in testosterone, but you also have erectile dysfunction, which has been shown very clearly by French researchers, because French researchers are very good at looking at sexual function. So, in the interest of time, I'm going to spend some time on this study and then wrap up. This is what is called a PCSK9 inhibitor. A PCSK9 inhibitor is something that you inject once every 2 weeks, and it goes and increases the amount of LDL receptors. So what happens is that your LDL levels go really down because the LDL receptor takes the LDL out of circulation. So this is a 28,000 patient study, 14,000 on the PCSK9 and 14,000 control. So you can see out here that patients that were given PCSK9, this is the Fourier trial, their LDL cholesterol was 30 milligrams per deciliter. Now that is an astronomically low number. Now these patients were followed for 2 years. The drug company itself decided to cut the trial short because they reached a statistically significant endpoint. But when you look at it, there were more people that died in the group that took the drug than in the control group that did not take the drug. But the party line was that this was a drug that reduced by a small degree the number of people having a heart attack. So this was phenomenal, this was revolutionary, this was paradigm shifting. So I borrowed this line from David Diamond, which says that dying with corrected cholesterol is not a successful outcome. So several people have said, you're being too harsh, but this is what I would like to say. Are we asking the right question? If you need 30,000 patients that is recruited in 30 different countries in 400 centers, and at the end you come up with a 0.5 to 1% difference in heart attack deaths, not even mortality. Are we asking the wrong question? Are we looking at the wrong problem? We are reducing LDL to 30 milligrams in 14,000 patients, so the magnitude of effect is large. We don't see a mortality difference. And rather than conclude that there is no benefit, we say, we didn't study them for a long enough time. We didn't study enough patients. So what I'm saying is that if you need a large sample size to show a small difference in outcome, the question itself is ridiculous. And I'm not sure if I'm being unreasonable in saying that. So I'm going to skip through some of these slides so that I can get to my points that I'd like to make. Before we get started on statins, should we get informed consent? Should the doctor talk to you and say, hey, I'm going to give you a potential 0.5 to 1% benefit, but that these drugs are intended for 40 to 50 years of use. That there is potential for biochemical and clinical muscle damage. That you may have problems with cognition, you may not sleep well. There's an increased risk of diabetes. Should we be discussing that there is potential benefit of having a high LDL level? You may live longer, God only knows if that is bad. Cognition may be better. You may be less prone to infections. I have several anecdotal studies that say, I have been on a low carb diet, my LDL number is about 250, but by the way, in the last 2 years, I've had no sinus infections. There is a defined risk of depression, there's a defined risk of neuropathy. So I would like you to eat like this. Cooking lard, butter, triple cream, fatty fish, fatty meat, chicken. When you do this, rather than this, which is the standard American diet, which is nothing but sugar and bread and vegetable oils, which is very inflammatory, which really gives you a donut or sugary fruit. What happens when you do this is that your good cholesterol goes down, your triglycerides go up, you become severely insulin resistant, but your doctor is very happy because your LDL does not go up. And like Ivor pointed out, 70% of the US population is insulin resistant. So this is my last slide, and I'm finishing a minute 25 seconds ahead of time. I think that we need education. We need more research on the functions of LDL. We need to see if it's involved in innate host defense, whether it does cell repair, whether it does important effects on cognition and memory. Our erectile dysfunction may depend on it. Our overall mortality may depend on it. The pharmaceutical company is not your friend. They are out there to make money. So my parting line is that the change in guidelines for both nutrition as well as for drug therapy is not going to come from the top down. It is not. It's going to have to come from the grounds up. You are the people who are going to have to go and teach your physicians, because now you have access to information like no other time, and you have leveled the playing field. Previously, the information that was available to medical professionals was here, and the information available to the general public was here. But now with the advent of internet, with people like Ivor, with people like Dave Feldman, who are putting out all this information for you to consume, it's an even playing field, and you have to get involved. Thank you.